you, Srinivas.
Thank you, Kuresh. Can you see the slide now?
Perfect, perfect.
Yes, yeah. Okay. So basically, we know that there is an increasing prevalence of dry eye in the recent times, and this has interested the pharmaceutical companies, and therefore we now have a lot of products which we can use to treat the dry eye, and therefore the interest in tests for dry eye has also increased. So no longer is it enough just to diagnose the presence of a dry eye, but we also now want to know what type of dry eye we have in that particular patient and what are the changes that are occurring in the ocular surface so that we can try and rationally choose the products that we have to try and match that particular patient's problem. The problem with the tests, however, are that they are not very sensitive and specific. And if you take a test result, it is often an overlap between the normal and the disease type. So we don't have a specific cutoff or marker in many of these tests, and therefore it has been suggested that the more tests that you do, the better you will be able to segregate the dry eye in a particular patient, and therefore the tests are proliferating, and maybe that is why Nikhil wanted me to do this talk on the diagnostic tests in dry eye. So this is the standard slide that we are using now because this is the DUCE-2 report, which is taken as the guideline by most people at the moment. So they said that we can ask a lot of questions, and if this suggests that there is a problem, then we do a questionnaire to document the extent of the patient's symptoms. And then we do these three tests, NIBUT, osmolarity, and ocular surface staining. And if there's a loss of homeostasis in any one of these, we conclude that there is indeed a dry eye. And in order to try and segregate the patient in the aqueous deficiency or the evaporative dry eye part of the spectrum, we look at the meibomian glands by meibography, we look at the lipid layer by interferometry, and we measure the volume of the tears. So the questionnaire, we can use the DEQ5, we can use the OSDI, we can use whichever one we like, helps us quantify it. And for instance, if you do the OSDI and if the score is less than 13, and this score is arrived at by taking the number of questions that the patient answered out of the 12, and the total cumulative score for each of these questions. And if it's less than 13, we think it's normal. And if it's more than 33, we think it's a severe dry eye. The DUCE-2 has highlighted tear film instability as one of the triggers for many of the problems on the surface. And therefore, they suggest that we do the NIBUT, which involves projecting a grid onto the corneal surface and looking at the distortion. The machine picks up the area of distortion, the time of distortion, and gives you the NIBUT. This is technically more physiological because you're not adding fluid to a fluorescein strip and then putting it on the eye. You're measuring the BUT in the original state. But if you don't have it, of course, you can do the fluorescein BUT. Hyperosmolarity is the other chief trigger. So you have to use a device for this, which most people don't have access to, the tear lab device. And if you put a sample of tears in it, and if the osmolarity goes up beyond 308, it is considered to be hyperosmolar. Or you look at a difference of more than 8 between the two eyes. The tear volume, we have traditionally used the standardized Schirmer test using the standardized paper and using a 5-minute readout on that 30-minute strip with a 5-minute hookup. And although there are several variations, it is a reasonable test provided you do it in a consistent manner. But if you want more quantitative measures, you can actually use a device to look at the tear meniscus under magnification and measure the height of the tear meniscus. Be that as it may, despite all of these tests, ultimately what we are looking for is whether the condition of interest is damaging the ocular surface, because ultimately that's all we are interested in. And that you could look at by doing fluorescein staining for the cornea and using either rose bengal or lissamine green for the conjunctiva. But if you have a slit lamp which has a yellow filter incorporated in it, the use of fluorescein alone will allow you to study conjunctival staining as well. Impression cytology can be done by taking a cellulose nitrate paper and pushing it onto the bulbar conjunctival surface or the area of interest. It could even be the cornea. You get a few layers of cells and you can look at squamous cell metaplasia, goblet cell density, and in the cornea, you can look for the presence of goblet cells if there's conjunctivalization, and there's a classification system that you can use. Because ocular surface damage tends to affect the nerves on the surface, there can be a loss of sensitivity, and you can use the Cauchy-Bonnet instrument. The Agit aesthesiometers are still in trial. They've not yet come out commercially. And the loss of sensitivity may correlate with the extent of damage on the ocular surface. Ocular surface inflammation, usually we use the redness score. The machine can take a picture and then you can compare it to one of these scales that are available, the Efron scale or the CCLRU scale, to give you a grading. But the other measures can be measured quantitatively using the measurement of the MMP9 level. And that is basically done using the inflammatory device, which is like the tear lab. which again is a problem because most of us don't have access to it. Other clinical tools that you can use is the extent of conjunctival staining, which you can detect with lissamine green, and this has been shown to correlate very well with the inflammatory markers in the ocular surface. Conjunctival edema associated with redness is a sign of inflammation. And if you see these lid parallel folds along the outer border of the lower lid, particularly in the temporal region, this is a sensitive sign. This is because when you have a lot of inflammation, the MMP9 cause a dissolution of the stroma, and the loose conjunctiva can then be thrown into folds. We have to look at the eyelid. You can anatomically assess the presence and function of these meibomian glands, but you can also have devices which do this by infrared meibography, and you can have algorithms which tell you the extent of dropout to quantify it. And you can look at the lipid layer itself. You can either look at it and look at it like this and assess it as normal, abnormal, or extensively abnormal, or you can actually measure the thickness of this layer using interferometry. The expressibility of the meibomian glands is something you can do clinically by pushing on the lower lid. You can look at the amount of meibum that is secreted, the quality, and the number of glands that are expressing it. And this will tell you some idea about the function of the meibomian glands. The lid closure is extremely important, not just to spread the tears across the surface, but also to result in tear clearance, and so tear turnover can happen. And if there is a poor lid closure or a lag of thalamus, then there will be excessive drying and hurting of the ocular surface. And that again, these devices can pick up by taking high-speed video photography and looking at the completeness of the lid blink. So if you look at the ideal tests, the ones that we would like should be easily available in all of our clinics, not just in an institute or in a specialized ocular surface clinic. The test should be easy to do using methods that we're all familiar with. They should be reasonably sensitive and specific. And of course, at the end of the day, they must be cost specific. So in a general ophthalmology clinic, this would be a good scheme of things. You could do the OSDI, which is cheap, freely available just to quantify the patient's symptoms. Look at the ocular redness score for the extent of inflammation. Look at a fluorescein BUT, and if you can do this consistently, it does give you valuable information. The fluorescein can also be used to look at the staining. Like I said, if you have a yellow filter, you can use it also to assess conjunctiva. But if you don't have that, don't bother. Just get a ₹1 lissamine strip, and that will help you assess it. Do a Schirmer for the tear volume, and do the meibomian gland assessment, both by anatomically looking at the glands and by pushing on it to see the secretion. If you have access to these options, then you could possibly make it a little better. You could do an NIBUT, you could look at the osmolarity, you could measure the tear meniscus height, you could measure the MMP9 levels as a surrogate marker of inflammation on the surface. You can study the meibomian gland anatomy and quantify the extent of dropout, and you can also actually measure the lipid layer level. So ultimately,
sorry to interrupt, doctor, but could you please wrap up in the next minute?
Last slide. So when you basically come to the end of it, you have to make sense of it all. So you look at the BUT, which is a measure of the mucus. You look at the Schirmer, which is a measure of the aqueous, and you look at the lipid and put it together to come up with a diagnosis of aqueous deficiency, evaporative, or a short BUT dry eye. To this, you add the presence of inflammation, the presence of ocular surface staining, and look for the other conditions that impact the ocular surface. So this would be a reasonable summary of the testing that we can use in a dry eye state.